Um, Today's Grand Rounds is really special for all of us, and certainly to me, Dr. Jamil Tajik. Dr. Jamil Tajik, once you hear the name of Tajik, few things flash in your mind. Run. Truly, his name is synonymous with echocardiography as one of the fathers of echocardiography in this country. His name is synonymous with leadership in the field, with passion for education and innovation, and truly shepherding the new generation of physicians, and a master clinician. So Jamil and I have known each other for many, many years, and it's been a wonderful journey of friendship and collaboration and seeing each other around the world. Jamil and I probably are among the few who, where they trained, they stayed, and they made their impact in cardiovascular medicine. Dr. Tajik came to Mayo Clinic in the late 60s and early 70s and stayed on. So this is where he did his cardiology fellowship and training. Stayed at Mayo for many years, where he rose through the ranks, and you know what his impact has been on echocardiography. And yesterday at dinner, we're talking about where his initial observations were really from case studies, where you see something that you may not know, and you research it more and have more observations and take it to a different level. And I think that has really marked his career of astute observations and taking them to the clinic and changing the field in so many ways. So Jamil, we're so thankful for all what you've done for the field. He was chief of cardiology at Mayo and head of the Zayed Cardiovascular Center at Mayo Clinic, and then moved to Aurora in 2010, where he headed the cardiovascular services there, and he's the director of the Specialty Clinic Center at St. Luke's in Milwaukee at Aurora. What can I tell you about Dr. Tajik? He has a true passion for teaching, and if you had followed his career, I know some of our new trainees may not know that, but he was the teacher of so many. He has received the Teacher of the Year Award at Mayo for many, many times, the Melvin Marcus Memorial Award Distinguished Gifted Teacher. Just to tell you about his passion for teaching and disseminating knowledge and information, 25 different courses for echocardiography and learning at the ACC Learning Center, 50 ACC ASE extramural courses, directed courses pretty much around the globe. And I'll name Germany, Austria, Switzerland, Spain, Italy, Turkey, Kuwait, Egypt, Pakistan, United Arab Emirates, and you name it. And Jamil, you're an amazing leader in this, and people try to follow, but they can't follow him. His areas of expertise are actually span quite a bit of cardiology. I know we'll talk about the mitral valve today and valvular heart disease, but hypertrophic cardiomyopathy, aortopathies, complex valvular heart disease, pericardial diseases, where Liv Hatley actually was in his laboratory for a few years, and I think they made quite a few discoveries about pericardial diseases and diastology. He was the ASE Edler Lecturer, American Heart Association Herrick Lecturer, Euro-Echo Lecturer, ACC Bishop Lecturer in 2003, William Harvey Lecturer at the University of Padua in Italy, and actually this is part of the impetus why you're seeing him today, and he'll talk about that. I just want to mention a few of the awards that I think caught my eyes, and I knew some of them, but not all of them. Ellis Island Medal of Honor Award. Distinguished Fellow, obviously, of the American College of Cardiology. And during my tenure as president of ASE, he was the first to receive the Lifetime Achievement Award of the American Society of Echocardiography. And the one that intrigues me and I like, and I don't think too many people are going to get, is Medal of Excellence from His Majesty, the late King Hussein. Not too many people who can claim that, Jamil, and I know he looked up to you in so many ways, medically and otherwise. So it's a pleasure to have Dr. Tajik talk to us about the mitral valve, and he'll tell you most likely why he's here, because we were at a very interesting conference, and I'm not gonna steal his thunder. And it was amazing, actually, symposium for mitral valve, and he gave the address for mitral valve, its history and its impact. So Jamil, what a pleasure having you today to give us an update on mitral valve prolapse. There you go.
Number one lesson, watch where you're going. Huh?
Okay there. Is he okay?
Okay.
All right.
Thank you. Well, thanks so much. Boy, that was a very, very generous introduction, very kind of you, and you're a friend, so a lot of extra things were said there, so thanks very much. It's my honor and privilege to be here. This is the place, and I've traveled around. I've been here before many, many moons ago, but you have something wonderful. Creation here, wonderful team I see, great things. I'm looking forward to spending the day with all of you, and also wonderful to see some nice old friends and young friends that are here, renew some friendships, so thanks so very much. Mike, whatever I'm going to say, you were there.
Yes, sir.
Yes. So, all things in cardiology, in life, are bimodal. They go up and down, up and down. So mitral valve prolapse, big time up in the 70s, 80s, then kind of disappeared a little bit. Other things came in, the valve disease, and now it's up again. So that's what we're going to go through a little bit. I'm very sorry to tell you there are no financial relationships. So I wish someday I will add something there. So this is the slide of the meeting that Bill just referred to. Last April, 2.5 days of meeting, a lot of people, about 30 faculty was there, Bill and I were there, devoted to mitral valve prolapse. And it was a wonderful, wonderful review, discussions, controversies at that time. I was telling Bill earlier on, after that meeting, he said, Jamil, you have to come and give some talk on mitral valve prolapse to us. I said, okay, and now I have about 30 minutes to tell you all that was discussed in 2.5 days. Well, it's not possible, so I've chosen just to cone down to a few things here. A little bit about history, favorite thing. One of my things to do is to look at the history and learn from it so we don't keep repeating mistakes. And words about diagnosis, prevalence, and then really spend more time on the morpho-functional characteristics that have been now paid a lot of attention to, mitral annulus disjunction, and finish with this group of high-risk individuals with mitral valve prolapse who we need to work hard to identify and prevent sudden death from occurring. So this is the timeline about mitral click and murmur situation. Has been known for hundreds of years, but always attributed to pleuropericardial origin. And you can see 19th century, patients came in, soldier's heart, irritable heart, they were all having these clicks attributed to chest in the pericardium and lungs and so forth. Famous cardiologist of France, Gallavardin, said, and that is 1913, that is a pleuropericardial adhesion that produce these clicks and these noises, and they're benign, don't worry about them. Our own famous Dr. Paul Dudley White also indicated that this is systolic click, probably coming from chordae rather than from the pericardium, so he came very close to the origin of the mitral click and murmur. Other cardiologist, famous Dr. Victor McCusick, in 1957, again came down to saying the click and late murmur is of extracardiac origin. And Barlow, so this is the valve we're going to talk about, but Dr. Barlow from South Africa was in the Royal Postgraduate Medical School in London, England. And in 57, he heard a click, patient died, he looked at the postmortem heart, and there was a calcified chordal structure, and thought that is the cause of the click. And then John Reed, another South African cardiologist, also at the same institution 4 years later, and he also felt that this was chordal snap. Now, interesting thing is, John Reed then published his observations in 1961 about the chordal snap. But 1962 is not too long ago, that's the way I think. Humphreys and McCusick at Hopkins came back, described electrocardiographic auscultation syndrome, so abnormal T waves and mid-systolic click murmur, but attributed to previous pericarditis. So that was up until by very famous cardiologists and observers, clinicians at that time. In 1963 is when this entity of click murmur, as Barlow described it, and established it. So this is his publication in American Heart Journal, October 1963. And he followed another one in 1968, where protrusion, aneurysmal. And he coined the term billowing mitral valve. And that is his main liking and fondness to describe that valve, and he did. I was there on his 50th celebration of this 50th anniversary in South Africa, Johannesburg. And everyone said that till his dying day, he hated the word mitral valve, prolapse. He wanted to be called billowing mitral valve leaflets. So as you can see, Gelabardin saying is extracardiac, benign, don't worry about it. It took 50 years. Half a century later, it was defined as the intracardiac origin of this. Then Barlow had another major discussion. Of course, he didn't like the word prolapse, which was coined by Dr. Criley in 1966 while at Hopkins. So the two of them are describing two different states of mitral apparatus. Morpho-anatomic status by Barlow, and functional status by saying prolapse, meaning it's regurgitating by that term. And Dr. Barlow died in 2008 after a stellar career in South Africa. Okay, let's move on now. Diagnosis. I think many know this person very well, Pravin Shah. Dr. Pravin Shah described 15 patients that demonstrated an abrupt, let's see, where can I point? There. An abrupt posterior displacement in mid-systole of the mitral valve from 3 to 10 millimeters, and this observation was made as an abstract, Circulation 1970. I must also point out, this is not a lesson the fellow should take. That abstract was never published as a manuscript. Very bad, okay? So Dr. Shah did this in 1970, but I also want to remind the fellows that he is also the person who delineated the nature of left ventricular outflow tract obstruction and hypertrophic obstructive cardiomyopathy by describing the systolic anterior motion of the mitral valve, which is referred to as SAM. Here it is, SAM. So in 69, he sees same, and in 1970, he describes buckling in systole of the leaflets, two very seminal observations by the same individual. So as he described it in this abstract in 1970, of course, immediately, before he could publish, others published it. Feigenbaum Group, Dillon, April 1971, showed beautiful posterior buckling of the mitral leaflets on the M mode, mitral valve prolapse. And in same month, April 1971, from Bill Hancock, this is late Dr. Kerber, 10 patients. So very few patients, both groups immediately published their observations. And the wording here says the mitral valve displayed an abrupt posterior motion in mid-systole coincident with the clicks, and that's what was observation of Pravin Shah, New England Journal. So April 1971. Remember that year because it started an epidemic. So after echo diagnosis by M mode of mitral valve prolapse took place, epidemic started. Now this is how nowadays we can get nice mitral valve prolapse. M modes are done routinely in the lab, and you can also see the thick mitral leaflet in this example, measuring about 10 millimeters here. Now the prevalence based on M mode echocardiography started getting published. This is 1975, just showing you the summary. 100 normals, Stanford normals, students and so forth. 21% diagnosed as mitral valve prolapse. Epidemic is, then people said, it can't be that much. So 700 volunteers, majority females, 6%. Then another big study, New England Journal, 1976. They studied 1,169 young women. And as you can see, most of the literature was focused that this is predominantly seen mitral valve prolapse in women. And they came up with, again, 6%. Huge numbers there. Finally, this is a seminal study from Bob Levine and Drs. Wayman Lab at that time and so forth that showed the true nature of the mitral annulus as a saddle-shaped annulus. Hence, by 2D echo, which has been introduced now, already you can also over-diagnose mitral valve prolapse, just like with the M mode echo now, and particularly if you're in the fourth chamber view. And I think you all know this, but this is where the whole prevalence aspect of mitral valve prolapse changed, and now it is completely regarded as still quite prevalent. It's very 2 to 3% of population, close to 8 million individuals in this country. Common etiology of patients who undergo mitral valve repair for degenerative mitral valve disease. And at the bedside is still a dynamic click murmur that moves with different maneuvers, and echo remains the gold standard for its diagnosis. So that's now very well established. So we are talking about two different types of mitral valve prolapse. It's important to know for prognostic aspects. The classic is referred to with thick leaflets, thickness greater than 5 millimeters, and non-classic are the ones that may have more benign follow-ups. So again, mitral valve prolapse can be syndromic, present in patients with Marfan syndrome, Ehlers-Danlos, Loeys-Dietz, and the whole list, pseudoxanthoma and so forth. But non-syndromic is what the discussion this morning is, and particularly on the Barlow syndrome. That's what my talk is concentrating on. And just in general, mitral valve prolapse can have a very benign course in majority of cases, but I want everyone to just be very familiar of some of the complications. Progressive MR leading to mitral valve repair eventually. Endocarditis should not be forgotten. Sudden death is what we'll be talking about, these kind of serious ventricular arrhythmias. And nowadays, a lot of focus on LV dysfunction as part of Barlow syndrome. Let me just skip this. These are different symptoms. But this is a follow-up study that was done at our place. Nishimura was the lead author of this study, looking at the long-term follow-up of patients diagnosed to have mitral valve prolapse. And in general, they did very good. But then there are individuals that we labeled high risk who develop complications. And the high risk, rather than go into too much detail, were identified by thick mitral leaflets. And thickness of greater than 5 millimeter came from that particular observation that we published over, close to 30 years ago. And that's what you see here. The complications of sudden death was there. And the sudden death now is considered on an annual basis between 0.2 to 0.8%. So it is still very high as compared to general population. And some of the other complications are listed as well of mitral valve prolapse. So focusing now on the morpho-functional characteristics, mitral annulus disjunction, and sudden death. Okay? Here is the classic Barlow's valve that you can see this tremendous myxomatous degeneration to the leaflets, hooding, ballooning aspects. You can see all of these multiple clefts formation to the leaflets is there. Very thick leaflet itself in between here. And not shown in this example are some endocardial lesions and fibrosis that develops in these left ventricles as well. Here would be the real gross example of Barlow's, looking from the left atrial perspective. And you see total beefy, thick leaflets as people have described them, given them different names. So this volume of these leaflets is excessive, tissue is excessive, and sometimes with tremendous degree of billowing, you have no regurgitation or minimal regurgitation. And you wonder how the coaptation is. It's because the leaflet volume has increased, surface areas has increased, so coaptation remains very well. So we're going to address a couple of aspects now with mitral annular disjunction. My good friend and colleague Maurice Serrano wrote this editorial comment which says, the forgotten component of myxomatous mitral valve disease. So it is forgotten because it was, in fact, first described by Saroja Bharti, eminent pathologist in Chicago from the lab of Maurice Lev and others that are listed here. And they described one patient, and thought it would be nice to share that patient's history. 45-year-old physician, long history of palpitations, exam, typical mid-systolic click, late systolic murmur of mitral prolapse. ECG revealed abnormal T waves, you got cut off here, and Holter monitor multiple episodes, short episodes of non-sustained ventricular tachycardia. So what was done? This is a pathologist writing it, so you know what happened. Huh? Whatever was done was not enough. But this is what happened. He refused further medical care. Typical physician, huh? I don't want anything, I don't want, and sudden death 1 year later. And that's how this heart came to be. So here was several things, harbingers of sudden death in his history, in his electrocardiogram and Holter, but he refused. On the bottom right is shown their first observation, and this is what is the first time. You can look at the top, 1981, when this observation was made. Annulus of this leaflet was elongated, and the valve was moved, hanging from the atrial side. So this is the top of the ventricular wall. Can you see that arrow? Yeah. on the bottom right. And here is the left atrial wall, and the valve is mitral valve leaflet is here, posterior leaflet. So there's major separation between the mitral leaflet and the wall of the left ventricle. Normal, the schema from their studies shown here, that normal, of course, we all know this is the atrioventricular junction, no space in here, but in this patient that has mitral annulus disjunction, they describe this finding. Separation of the two, atrial wall, mitral connection is separated from the ventricular wall. So that's 1981. This is the major study 5 years later from Johns Hopkins, from Dr. Grover Hutchins. And 900 hearts were examined. And note, 3%, again the same prevalence that we talked about nowadays of mitral valve prolapse in general population. 3% of the hearts had a morphologically typical floppy mitral valve. 23 of them, or 92%, the mitral annulus fibrosis showed disjunction. 42 other normal hearts, other hearts that didn't have floppy valves, 5% also had small amount of disjunction, he noted. And this is what he speculated, and I should point out that Dr. Bharati and colleagues also speculated the same thing. So pay attention to this statement, because that's where the field is thinking and moving now in this whole mitral billowing valve syndrome and high-risk individuals. We suggest that the floppy mitral valve develops from hypermobility of the valve apparatus, and that is usually secondary to disjunction of the mitral annulus fibrosis and anatomic variation in the morphology of the annulus. So it's the disjunction leading to hypermobility, leading to myxomatous degeneration of the leaflets. The speculation proposed hypotheses of two very senior pathologists in their observations. So this is what, as clinicians, we need to keep in mind. Bharti said, and Maurice Lev said the same thing in their case report, and this is what this individual says. So schematically, you are seeing the annulus disjunction noted right here. Here's the LV wall, and here is the this is the left atrial wall here, and here is the mitral posterior leaflet. So the separation is quite evident both in the long axis view and in the apical long axis view. So in 2010, this was a paper published by ECHO to show how to detect disjunctions. So we are just in the early phases here. Let me show you an example or two of that. 42-year-old patient with leaflet mitral valve prolapse, cardiomyopathy, LV dysfunction, ICD is implanted in this person. And you'll see the disjunction is evident right here, quite marked, 15 millimeter. Real time, you can see that, how that disjunction is taking place, and then watch that posterolateral wall of LV, how it moves like a piston, moves towards the apex, jerks like that, and at the same time the papillary muscles are pulled by the billowing leaflets. So it's a fascinating thing taking place at that corner of the heart. High stress, high strain area in these hearts, okay? That you saw, this patient again you can see has mild MR, and there's the ICD lead you see in the right ventricle. Again, billowing leaflets, you can see overall left ventricular function is reduced. And here in the apical long axis view is the other nice view to see disjunction, which is evident here very nicely, right in this corner with systole, billowing leaflets. And note that this wall is a little bit thick as compared to the remaining walls, and it is just being pulled, actively contracting this way till the mid-ventricle. So you see all those findings: annular disjunction, annular systolic increase, annulus dilates during systole in these patients, systolic curling. This is the curling motion, also referred to as the ballerina foot deformity, as was first described on angiograms. Localized hypertrophy of the basal LV wall. And here you can see bullseye of this patient, and note that that level of the papillary muscle, the strain is extremely high, both at the base and at that level, measuring minus 32%. Tremendously high strain. So something very peculiar in that region takes place. So who are the individuals at high risk? How can we identify them? It's always a very tough process, never completely accurate, but attempts should be made. We need to identify individuals like this. A recent patient presented with syncopal episodes and has mitral prolapse, disjunction, the whole thing, and this was repeatedly seen on his monitor examination. Fast, non-sustained ventricular tachycardia. Now, and we said Padua, Italy was this meeting because that is the center where some of these very seminal work on this area of sudden death, disjunction, annulus abnormalities have come out. They are very excellent cardiac pathologists, Cristina Basso, and I've listed Gaetano Tin, another Top Gun, world-famous pathologist, and Sabino Lecito as the head of cardiology at that center. And this is the first study they published, and look, this is an autopsy study, and they are able to look at autopsy of 650 young adults under the age of 40. They were diagnosed to have sudden cardiac death and were diagnosed as cases with MVP. And basically they find 7% of all sudden cardiac deaths in that region attributed to mitral valve prolapse, floppy mitral valve prolapse cases. And the observation is that these patients have fibrosis of the papillary muscles and infrabasal left ventricular wall, suggesting myocardial stretch. Stretch has been mentioned since the very beginning of echocardiography and angiography, that stretching of the papillary muscles, stretch-induced rhythm abnormalities are the basis of all arrhythmias in sudden death here. And now these pathologists conclude that this is the basis for producing localized fibrosis to that segment of the heart. It's hypercontractile and then eventually starts getting fibrosed and so forth. So on the top row are sections of the basal LV wall, post-basal wall right here, and this blue staining areas, of course, all represent fibrosis. And that's what you're seeing, fibrosis there and fibrosis around the area of the wall of the left ventricle where the papillary muscle is, and also involving the papillary muscles right there. So this was their seminal observation, and then they went ahead and did the second clinical study because they know the MRI is the way to diagnose scar tissue in life. So that's how they did this study, which was to describe the morpho-functional abnormalities of mitral annulus and arrhythmic mitral valve prolapse. Again, here they are, all of them listed, and I will come down to say, basically in conclusion, the mitral annulus disjunction is a constant feature of arrhythmic mitral valve prolapse syndrome, and that is where the fibrosis identifies patients with fibrosis. And that's the excessive mobility of the leaflets caused by this curling of the annulus and the LV wall results in myocardial stretch. So again, we are coming to a unifying kind of thought process that from the disjunction develops the curling of the walls and increased stretching of the papillary muscles from the prolapsing leaflets. They did a very elegant MRI study, of course, and this is images from their paper showing how they measure the disjunction and the amount of prolapse and the curling aspect of the angle and the posterobasal wall being hypertrophy, localized hypertrophy of that segment. And again, showing the fibrosis, and the greater the disjunction, the more the fibrosis. So then another study based on MRI, this is from Dr. Delling, who in the field of mitral valve prolapse has done quite seminal work in regards to epidemiology, working with the Framingham data set. Now she's in UC San Francisco. And her observations, or their observations, were only in 41 patients, that there is diffuse interstitial derangement linked to subclinical systolic dysfunction. So they think there's diffuse LV fibrosis, and T1 imaging is what was detecting this type of abnormality, not necessarily LGE type of data. That was published in Heart 2017. And recently in the Heart, this Dr. Zoghbi, and some of these names of these people that I'm referring to, they were all present at this international meeting presenting their latest observations. 68 pathology specimens with sudden cardiac death and mitral valve prolapse, and then majority had microscopic left ventricular fibrosis, some hypertrophy, features of myocyte degeneration. This is microscopic study showing fibrosis of the myocardium and cytoplasmic vacuolization, meaning cells are dying in those areas. So that's another paper pointing this out. Does anybody recognize this paper? Huh? Okay. Wonderful work, nice. It adds another very important piece of information, larger number of patients done here. Congratulations to all of you to getting this done. Again, summary of this paper is showing that most of this fibrosis or delayed enhancement is posterobasal level locations in patients with mitral valve prolapse syndrome. And non-mitral valve prolapse syndrome with mitral regurgitation is different distribution anteriorly, laterally, but this is where the localized issue is. So all things are pointing to the same. All studies to date are showing the same aspect. To look at the myocardial aspects of the billowing valve syndrome, Barlow's valve, this is another very elegant way of analysis using the 2D speckle tracking in mitral valve prolapse and to see post-systolic shortening, okay? Okay, so let me just come to their main image. There's a schematic of the image showing that most of the shortening is complete at the time of aortic valve closure, and then these abnormal segments located posterobasal lateral wall show abnormal post-systolic shortening. End of systole should be here, aortic valve closure, and they are still here. Thickening is taking place, while the other segments are relaxing. So incoordinate contraction relaxation is going on, also a milieu for arrhythmogenesis. And this was their data there. So this is the central illustration on a most recent paper on arrhythmic issues in mitral valve prolapse in JACC. I have modified this to kind of, and my secretary has given all the colors, so she loves doing all the colorful aspects, and I say, okay, keep going. Never want to annoy your secretary, by the way, okay? So here we have, she does beautiful work, I must say, I like it. So again, you can see that you have to have a substrate What is the substrate? Scar tissue formation, best detected with cardiac MRI, not locating infrabasal wall and tip of postomedial papillary muscle. Myocardial stretch by disjunction, which can be seen equally well by echo and MRI. Then something I'm going to just talk about for a few minutes. What time is it now? We have a few minutes? Okay. Is this mechanical stretch that we observed with the tissue Doppler, and of course all these leading then to major arrhythmias. So list of high-risk markers are shown here, but as you know, when you have such a long list, you know nothing is highly specific. It's just a combination of things that we can put together. But right now, a lot of attention is to this lower part of the slide. Bileaflet prolapse, fibrosis, annular disjunction, and this paradoxic expansion of the leaflet. So ballerina foot deformity, I briefly refer to that, localized to the basal portion of the heart with this hypercontractile area here is a prolapsing valve. And our focus was also on tissue Doppler and strain imaging to that very area of the heart. So what is there that we can detect? And lo and behold, you do detect something which is a very peculiar spike, looks artifact. And I'll show you a couple of examples and ask if you guys have been looking for it as well. We published this observation as a letter to the editor in JACC Imaging and called it pickle hobby sign. Now we are in Milwaukee, a German town, so it was very appropriate to select a German helmet with this big spike coming out of that, which is the pickle hobby, referred to as pickle hobby, this one. Big spike in the middle, because the initial ones of these images just look like that. Now we are seeing some that are a little off in timing, but otherwise right in mid-systole when the prolapse is taking place and this jerking motion is taking place, we see on the tissue Doppler in that area of the heart tremendous this thing. And that's what you're seeing, this big jerking going on, okay? Of the papillary muscle and of the postobasal wall. And this is the spike that comes out. In that area, it's lateral wall or infralateral wall at the base, you'll see this tremendously high, 30 cm. As I said, this was looking. And then we looked at the strain at that level. And you'll see that strain bullseye or so. This is minus 38 at the papillary muscle and in the upper 20s at the base. Huge, very, very high strain values. So that is what is going on and what everyone's speculating, but now we can quantitate it based on this methodology. So here is a patient. I'm just going to show a couple of examples and we'll end. 49-year-old, typical classic mitral valve prolapse syndrome. She is symptomatic as well, and murmur, non-sustained VT. So we did primary prevention in her because I was very concerned. And she finally agreed, reluctantly agreed to have an ICD implanted. 7 appropriate shocks over the next few years. And then her MR was moderate. We said, I think we need to fix. And these are some of the examples of her non-sustained VTs. A little bit slower, 150, then fast one, then she'll get pre-syncopal and so forth. Now this one is not, oh yeah, there. See her long axis views a little bit, you saw, very myxomatous leaflets, but you'll see again. Let's note that the MR is not severe. It was more kind of mild, upper mild, low moderate zone, thick leaflets, bileaflet prolapse, mitral disjunction. You can see all that in real time. Calculations, 32 ml regurgitant volume, ERO 0.2, and note her spike, 40 cm, lateral annulus. Medial, of course, is normal. And again, if you watch the screen on the right, you see how the papillary muscle area and the whole wall in that region is just being tugged by the thick prolapsing leaflets. Okay. Just to appreciate that in a little bit slower motion. You saw these numbers. Let me just, and here you'll note we're doing the analysis of the regional walls and the delayed contraction, post-systolic shortening of those two segments of the wall are seen. So that is where all the action is, and why it is there, because that is the area under tension. So with all her history, I decided we need to proceed with mitral valve repair, left atrial reduction, and the whole thing, and successfully has been done. You can see now that left atrial is small, leaflets are repaired well, no more disjunction, and she's doing well. This is not a long-term follow-up, but a short-term, medium-term follow-up, doing okay. No ICD discharges, and she feels good. And there's the pre-op spike, and this is the post-op in her case. 43-year-old male, same symptoms, lot of rhythm, but her MR, his MR is more on the severe end, and you can see there's little incomplete coaptation, flail-like segment posterior leaflet, but watch the left ventricular free wall there, the area of the papillary muscle and around. The spike is huge coming from that area, and so is the total GLS is minus 23, normal, upper normal, but regional one right at that spot is very high. After repair, findings of this, doing very, very well. 51-year-old patient currently under our care, lot of ventricular rhythm issues, being controlled with medications, doesn't want to think about surgery. And you can see findings are typical mitral disjunction by leaflet prolapse. The leaflet are not as thick as other example I just shared. Again, mild to at the most moderate. And in contrast, her post-basal wall is on the thinner side, not hypertrophied. So these are the MRI echo images side by side. Mostly the same image by both. When you come to structural analyses, you see pretty much the same findings, but you know the value of MRI is to provide that missing piece, which is the how much scarring is present or not, and if present, what's the quantitation of this apical long axis view. And in this patient, the scarring was very clearly seen, involving the papillary muscles. Right here, posteromedial papillary muscle, posterior basal wall of the LV, and here tip of the posteromedial papillary muscle. Here the leaflets are also lighting up, and same tissue. So then if you go back and look at that, I was surprised to see that anterior wall was very high strain in this patient. So that was surprising. So we do this systematically in our patients, all 4-level tissue Doppler analysis. Highest spike that I could find was at the usual apical long axis at the base. 2-chamber, 4-chamber, no. Anterior base where the tissue Doppler is not picking up what strain is picking up, and others. So that way systematically look is done and find the highest area. Just to finish with this case, okay? This is a 74-year-old. And note she has all the features that are for high risk malignant cases. Bileaflet prolapse, thick leaflets, mitral annulus disjunction is very marked, very obvious, very clear. Posterobasal wall of the LV is localized hypertrophy. Look at the pulling and jerking of the papillary muscle is going on big time. She has mild MR, not much more than that, and late systolic typical spectrum of that. Here she is 74-year-old and doing well. Moving on. I've been following her for a few years, starting a little earlier on. This is the latest echo on her. So you can see her findings, both studies, echo, MRI. Echo, MRI, long axis, apical long axis, same thing. You can see post-basal wall hypertrophy, post-basal wall localized hypertrophy, disjunction is there, very nicely seen. But she did not have much of fibrosis. And that is one of the important negative findings here. And her spikes were not huge. They are there, but they're not huge. Okay, so let me stop here. I know there are more examples, but I just want to thank all of you for inviting me, number one. Number two, this area of mitral valve prolapse, billowing valve, arrhythmic issues is a whole new area of excitement because patients are at risk, they don't know it. Most patients are regarded mitral prolapse, benign condition, not truly paid attention to follow-up. We are going through very systematically, as all should be doing, look at these patients with high-end imaging as well, and trying to decipher those individuals. And the one I showed you, by preventing sudden death in that lady by primary prevention is the key to move forward. But yet more to learn, waiting to hear from all of you. Thanks again for your kind attention.
Thank you.
Yeah.
We have a few questions for Dr. Tajik.
Thank you, Jamil.
You're on.
Thank you, Jamil. That was fabulous, as expected.
Two questions. First one is just a simple it has been taught for years that MVP is more common in women, but frequently men tend to get more complications. Now, is that really true? Because what you show here were actually a lot of women having the sudden death syndrome and whatnot. So where do we stand in that thought that men have more problems than women?
Just generally right now, I think because so much has been taught to us over the years, females, and thin, skinny female in particular, straight back and so forth, that males get disregarded actually. But what is happening is because females are considered that they're symptom complex, autonomic dysfunction, and anxiety related, do not get proper attention. It's like true for mitral valve prolapse as it has been in other forms of heart diseases, and they do not come to proper attention. But in general, I think you'll say they're about equal. But somehow older males have more rupture chordal apparatus.
Right. Now to the more serious question, the syndrome of sudden cardiac death, although rare, it affects in general younger people overall. An ICD, which is a piece of wire in your heart for 30, 40 years long term, has its cumulative incidence of problems. Is it time to start getting together and thinking of some prospective trial or something on mitral valve repair as a preventive measure, even if the MR is not so bad? Because your observation, I think, is one that we also have seen, is that when you repair the valves, you see a lot less of that movement and hopefully less of the arrhythmia. So is it time to start thinking that way instead of waiting for the MR to be, severe, blah, 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 blah?
I think you're hit it on the nail, that is the way to start thinking. What is to be done in these individuals for long term, how to prevent something. So most of the autopsy studies, these are young people who have sudden deaths, and they're tragic, and so forth. So this is where I think you have good valve surgeons, then maybe that is one way to approach it. It does not totally eliminate it. The series that came out in small numbers from Mayo, points towards that as a possible one, but again, these are select small series. It doesn't fully prevent it. It still is there because it depends on how much fibrosis has developed. That's not going to go away.
Talking about famous surgeons, Dr. Lowry.
Oh, welcome, and it's a pleasure to get the opportunity to hear from you. I'll preface my remarks by saying that my great teacher, Dr. DeBakey, many times would comment in the presence of cardiologists that he didn't understand how people who had never set eyes on what they were talking about spoke with such authority. So having looked in at more than 3,000 mitral valves, I have a little bit different perspective on some of the details of what you mentioned here. I think we're all in agreement that traction occurs on the papillary muscle in certain patients with mitral valve prolapse. The traction is coming from pulling on the chordae. The chordae are attached to the leaflets, and notably absent from all of these papers, which I have read and followed, is any description of the surface area of these leaflets and any calculation of the strain they produce on the chordae and the papillary muscles. And you're probably aware our group with Dr. Zoghbi has done a lot of work on strain patterns in people with mitral valve prolapse.
Yes.
And people with mitral valve prolapse typically have high strain patterns on their leaflets, which is at its maximum in the Barlow's group. So that's number one, going back not from the annulus to the papillary muscle, but from the papillary muscle backwards towards the annulus. We now have pathological studies, some of which, including Dr. Hutchins, clearly show that mitral prolapse occurs without disjunction, and Barlow's disease frequently occurs without disjunction. And we have very good studies, particularly from the famous group in London, whose name eludes me right now, but he did a controlled study of normals and people with prolapse and showed that the annulus is a mixture of disjunction and non-disjunction in all people. And everyone in this room has a little spot of mitral disjunction posterior to the membranous septum.
I think some have it, yes.
Everybody. 100% of the people in this room, posterior to their membranous septum, have a little area of disjunction.
I think you're referring to Bob Anderson's.
Dr. Anderson, yes, correct.
And they wrote a letter to Hutchins, also kind of challenging that concept. But
the point I would like to make is that the strain on the posterior annulus is extremely high in all people with big leaflets.
Yes.
And that manifests itself with fibrosis and calcification. And yet, none of the literature you've described mentions the annulus as the source of the arrhythmia. The source of the arrhythmia is from around the base of the papillary muscle. So what I'm going to suggest is the heretical suggestion, and then the other thing is the left atrium attaches in a very variable way to the mitral leaflets. And on echo, I would suggest you cannot tell the difference between a left atrial wall that's attached to a myxomatous valve that is then stretched up from its annular attachment and disjunction. So disjunction in a rigorous manner is really a histological diagnosis, and there is a wide variation in how the left atrium, the mitral leaflet, and the annulus are arranged with each other. And I really believe this current frenzy and the focus on disjunction is misguided. The problem is these huge leaflets.
Yes. No.
And we've demonstrated repeatedly with strain measurements that simply replacing the leaflets back down into the left atrium puts the strain level back to normal without touching disjunction or doing anything to the annulus. That's a totally unnecessary step in any surgical correction.
So I think, thanks so much for your insight, comment, and very nice ones. I agree that the leaflets are big sales, and they have a volume. The question is, and we don't have this longitudinal data, follow-up is, a same patient, depending 10 years, 15 years ago, how was those leaflet status? and what has happened over time. You know, is it progressively become more and more voluminous, and now we are seeing the rhythm issues, or how is this happening type of aspect. I think to me, when I was discussing even at that meeting, because they are very focused on the annulus as the primary, disjunction as the primary one, you think it's more beyond that. It's nothing one. It's just leaflet structure, annulus disjunction,
I just
and
suggest-
hypercontractility. There's a element there of hypercontractility going on that is localized to that portion of the heart, which is finally causing, wear and tear.
Well,
And
the base of the papillary muscle has always been a potent source of origin for VT. And so it's very reasonable to think that adding mechanical stress that leads to fibrosis, which is the patchy fibrosis, is a substrate for VT. That's all extremely logical. Every part of that I agree with. But for some reason, people are skipping from the annulus to the LV wall without stopping to think about what's going on with this gigantic structure that's doing the pulling.
Yes. Not forgetting it, it's there.
But I'd suggest people start measuring and reporting the relationship between leaflet size and disjunction, because I think that they're using a marker, an indirect marker of leaflet size as one of their parameters instead of measuring the primary problem, which is the leaflet size. The attachment of that huge leaflet at the annulus doesn't cause anybody any problem. There's no arrhythmias, and it doesn't cause heart failure. The problem is where everything's pulling on the papillary muscle.
The papillary muscle.
May I ask a question just to, as you're repairing these valves, what is disjunction? Does it come into play at all as you?
No, I'd suggest that it's irrelevant. And Tyrone David published a paper on this, and he wasn't able to show any benefit. No surgeon has ever published any data showing any benefit from addressing disjunction as part of the repair.
That
That
was one
doesn't
of their
exist
first
in the
papers
surgical
they
literature.
published.
What's that?
On the TE that they were publishing, they raised that question that the surgeons have to be very aware of this because it can result in residual MR.
No, that's totally false. I mean, if you pursue the Carpentier technique of mass destruction of the mitral valve and call it a repair, then you may have that problem. But if you preserve the leaflets and put them back where they belong, it actually is beneficial to have the maximum area you can, because you get the lowest strain levels post-op. The Carpentier repairs, which are probably what you're talking about, all come out with elevated strain. Their mitral valve leaflet strain is greatly elevated post-op, which is probably a bad thing for these people.
Okay.
A lot of food for thought.
Yeah, a lot of it. There's another question someplace.
One more question. Let's see.
It seems
Where are we?
Dr. Shah, got any comment?
it seems to me that
They've looked at a lot of our mitral repair, and I don't think you see problem. I don't think you commented on the annulus being distorted or in some terrible state because we haven't addressed disjunction. I've never seen disjunction mentioned on our post-operative echo repairs.
Any other questions? All right. With that, thanks for having
Very good, very good. Thank you. Neat.
One question.
Yes, yes.
Now that everybody and their mother gets an echo,
Huh?
now that
Hello, I'm Young Park with the Houston Methodist DeBakey Heart and Vascular Center. I'd like to invite you to the 4th Annual Houston Heart Failure Summit on February 8, 2019 at the Houston Methodist Research Institute. The Houston Heart Failure Summit provides a comprehensive update on the prevention, diagnosis, and management of heart failure. Experts in the field present these topics, and you will be able to engage in panel discussions and case-based presentations. Sessions will cover the most recent treatments for chronic heart failure, pulmonary hypertension, hospital admission, as well as treatment options for cardiogenic shock and end-stage heart failure. This one-day conference, which offers continuing medical education credits, is designed for physicians, physician assistants, nurse practitioners, nurses, and other healthcare professionals in cardiology and cardiovascular specialties, internal medicine, and family practice. We also encourage residents and fellows in training to attend. I hope you will join us for the Houston Heart Failure Summit and look forward to seeing you in February. Please explore our website for more details. Thank you. Hello, I'm Myung Park with the Houston Methodist DeBakey Heart and Vascular Center. I'd like to invite you to the 4th Annual Houston Heart Failure Summit on February 8, 2019 at the Houston Methodist Research Institute. The Houston Heart Failure Summit provides a comprehensive update on the prevention, diagnosis, and management of heart failure. Experts in the field present these topics, and you will be able to engage in panel discussions and case-based presentations. Sessions will cover the most recent treatments for chronic heart failure, pulmonary hypertension, hospital admission, as well as treatment options for cardiogenic shock and end-stage heart failure. This one-day conference, which offers continuing medical education credits, is designed for physicians, physician assistants, nurse practitioners, nurses, and other healthcare professionals in cardiology and cardiovascular specialties, internal medicine, and family practice. We also encourage residents and fellows in training to attend. I hope you will join us for the Houston Heart Failure Summit and look forward to seeing you in February. Please explore our website for more details. Thank you.